So you're planning on starting an antidepressant, but you're a little nervous because you don't know what to expect. Well, in today's antidepressant mini course, we're going to be answering questions such as, do antidepressants really work? How do you select the best antidepressant for me? When will my antidepressant start working? How long do I need to stay on my antidepressant? Am I at high risk of having withdrawal symptoms when stopping treatment? And how do I come off of my antidepressant? By the time this video ends, you might know more about these medications than even your prescriber. If you're new to this channel, welcome. I'm Dr. Allie and I'm a board-certified psychiatrist. The goal of this channel is to provide you with mental health education so that you have the tools to feel better faster. Before we dive into this mini course, make sure to check out the link below if you want to download my free antidepressant beginner's guide. Because in this, I break down the pros and cons of the top 10 antidepressants that are currently being prescribed today. Now, the first major question that we need to answer is, do antidepressants really work? Okay, so this question has caused some debate in the medical community, and researchers used to say that only about half of the antidepressant trials in the FDA database showed that antidepressants were more beneficial in treating symptoms of depression than placebo. And this is important, especially when 1 out of 10 Americans aged 12 and up are taking an antidepressant medication, because no medication comes without the potential of side effects. So if we're going to be prescribing a medication to you, we want to have evidence that it's actually going to help. So in 2018, The Lancet published a comprehensive review that included 522 double-blind studies and over 116,000 participants. Let me repeat that in case you didn't catch it. 116,000 participants. And after evaluating 21 different antidepressants, they concluded that all the antidepressants studied were more effective than placebo in treating adults with major depressive disorder. And this is especially true when we're treating the most severe forms of depression. There's multiple studies that show evidence for this and back this claim up. Not only that, antidepressants have been shown to achieve higher rates of remission and have been shown to help prevent relapse of symptoms. Now, in order to fully understand whether or not antidepressants will be helpful in treating your symptoms of depression, I first want to talk about some of the common terms that are used in psychiatry when discussing treatment efficacy. We refer to these as the 5 R's. The first term I want you to know about is response, and this is when someone who is being treated for depression gets at least 50% improvement in their symptoms. And this used to be the goal of treatment, but now we are aiming for remission. And this is when you become symptom-free. If you remain symptom-free for at least 4 months, then you are in recovery, and this is beautiful. Now, what happens when symptoms start to pop back up again? When your symptoms return before you reach remission, or within the first few months prior to achieving recovery, then you have relapsed. And if symptoms pop back up after recovery has occurred, then the term we use is recurrence. So the 5 R's are response, remission, recovery, relapse, and recurrence. Okay, so now that we're all speaking the same language, let's answer the big question. Will an antidepressant be helpful for you? Well, one of the most popular and largest antidepressant studies ever conducted was the STAR*D trial. And one of the main goals of the study was to figure out the remission rates of depression, right? And remember, remission means symptom-free after treatment. And what this study suggests is that your chances of achieving remission with the very first medication you try is somewhere around 37%. Okay, so now you're wondering, what happens if my first medication doesn't work? Do I try a second medication? And the answer is yes. This study took those who didn't achieve remission after their first medication and then either started them on a new medication or added on a helper medication. And then this process was repeated for a 3rd time and then for a 4th time if needed. The good news is that with each treatment course, more and more people were able to achieve remission. And by the end of 4 treatment courses, almost 70% of people became symptom-free. And that is freaking awesome. Now, the downside is that the odds of beating the depression with medications alone decrease with more medication changes that you need to make. And this is especially true after 2 medication regimens have failed. And this is part of the reason why treatment-resistant depression is defined as 2 antidepressant failures. Now, It's important to remember that just because some people didn't achieve remission, it doesn't mean that they didn't have symptom improvement. So I don't want you to get discouraged with this. It's estimated that around 50% of people will respond to antidepressant drug treatment, meaning that we'll see at least 50% symptom improvement. Okay, so you might be wondering, why do we care whether or not someone achieves remission, right? Shouldn't getting a response and overall symptom reduction be good enough? And the answer is no. Symptom reduction is not good enough. The more symptoms still present and the more treatment failures you have, the lower the chance you'll have at achieving remission. Not only that, data shows that you'll also have higher relapse rates, so we really want to intervene as soon as possible and try to get you to be symptom-free, because this might prevent disease progression. This is an important point to understand, so if you need to, go back and listen to this again so that you can hear it and process it another time. So now you might be wondering, which symptoms are most likely to persist and continue to be present in those who aren't completely symptom-free? The most common ones that linger and have a difficult time going away are insomnia, fatigue, pain complaints, cognitive problems including poor concentration, and lack of interest or motivation. What we see is that treatment of major depression seems to work best in improving symptoms of depressed mood, psychomotor slowing, and suicidal ideation. So now that you know what to expect efficacy-wise when starting a medication, the second big question to answer is, how do you select the best antidepressant for me? Well, there are 8 major factors that doctors commonly take into consideration when helping patients select an antidepressant. Factor number 1 to consider are your current symptoms. There are many antidepressants to choose from, and what we see is that some medications are better at targeting certain symptoms than others. So for example, if you're having trouble, say, falling asleep, choosing a medication that is known to be more sedating could be a good option. So something we'd consider starting would be like mirtazapine or trazodone. But if you're struggling with, say, low energy and motivation, you might benefit from an antidepressant that has more activating properties, so something like Wellbutrin or Effexor. So during your evaluation, it's always helpful for your physician to know about some of the secondary symptoms of anxiety or depression that you're struggling with. The second factor to look at are your past medication trials. If you've tried an antidepressant in the past that was helpful in improving your symptoms, trying that medication again could make sense, right? On the other hand, it's also as equally important to know which medications didn't help you, whether it was due to it being ineffective or if it was due to you having intolerable side effects. My goal is always to find the medication that will give you the most bang for your buck. So we want it to be both effective in treating symptoms and in giving you the least amount of side effects possible. Now that we're on the topic of side effects, factor number 3 to consider are the various side effect profiles of the antidepressants you're choosing between, right? Side effects will vary from medication to medication and from person to person. But with that being said, some antidepressants are more notorious than others for causing issues. So for example, Paxil or paroxetine is typically regarded as being kind of the problem child of the SSRIs because of its potential to cause things such as weight gain, sedation, sexual dysfunction, and withdrawal symptoms with missed doses. Factor number 4 to consider are your other health conditions. We want to make sure that your antidepressant won't worsen any medical or psychiatric conditions that you've been previously diagnosed with. For the females out there, it's also important to know if you're planning to become pregnant, are currently pregnant, or are breastfeeding, because some medications like Zoloft or sertraline are often more preferred than others. Also, don't forget that some antidepressants are double whammy medications and that they can treat multiple conditions. So for example, Cymbalta is commonly used to treat not only depression, but also to help relieve pain symptoms or fibromyalgia. And Wellbutrin is another good example of this type of medication. Other things that it can treat include things like smoking cessation or symptoms of ADHD. The 5th factor that I'm constantly asking about is whether or not your family members, particularly your first-degree relatives, right? So your parents, siblings, or children are taking antidepressants. Sometimes we like to use genetics to our advantage, and what works for them might also be what works for you. Now, the 6th factor that I like to ask about is whether or not you're someone who is going to have a hard time remembering to take your medication every day. And if you are, then you're going to want to choose an antidepressant with a longer half-life, right? Such as Prozac or fluoxetine. And avoid medications with shorter half-lives, ones like Paxil or paroxetine. If you're on a medication with a short half-life and you forget to take it for a day or two, you might feel it because you're going to be at high risk of experiencing withdrawal-like symptoms. So things like agitation, anxiety, insomnia, flu-like symptoms, and the list goes on and on. So be honest with your doctor when talking about your difficulties with medication compliance. Factor number 7 to think about are the other medications you're currently taking. Some antidepressants are notorious for having drug-drug interactions, and this has the potential to lead to serious adverse reactions. So make sure your doctor knows about the other medications that you're currently being prescribed, in addition to ones that you may be obtained over the counter. The 8th factor that you need to take into consideration is the cost of the medication. You'll always want to do a little digging and check with your insurance company on whether or not your medication is going to be covered. Some of the newer and fancier antidepressants will only have brand versions available, and they could be very expensive if not covered by your insurance. But the good thing is that the majority of first-line medications that we commonly use today have generic options available. So make sure to talk about this further with your doctor. And don't forget, always check for medication coupons or discounts, whether it's on the drug manufacturer's website or another site like GoodRx. Now that you know about some of the important factors we take into consideration when starting an antidepressant, the third major question to answer is, how long will it take for my antidepressant to start working? One of the first things I tell my patients when starting an antidepressant is that this is not going to be like when you have a headache and you take a Tylenol or an ibuprofen to make it go away quickly. Antidepressants need time to build up in your system before you notice a positive benefit. Now, how much time are we talking about here? Multiple studies have looked into this question, and what decades of research tells us is that you can expect to achieve a positive response or even full remission by 6 to 8 weeks. Now, this doesn't mean that you won't notice any benefit prior to this time. There have been several studies conducted that suggest that we can see symptom improvement within the first couple weeks of treatment, and this is a true antidepressant effect and not just some sort of placebo response. So this can include improved mood, better sleep, energy, or motivation. You might be finding hobbies to be more enjoyable, or you might even notice a reduction in suicidal thoughts. Now, when should you be concerned that the medication you're taking isn't working? And how do you know if you need to make a change? Okay, so research suggests that if your condition isn't at least minimally improved by the end of 4 weeks, you should have your treatment regimen altered. And this might mean that you increase the dose of your current medication, or you might switch to a completely new medication. And the reason behind this is that if you haven't noticed any sort of improvement by the end of the 4-week mark, the chances are very small that the dose you're currently on will ever be effective at managing your symptoms. Now, on the other hand, if you're showing even a small amount of improvement by the end of this 4-week mark, data shows that there's a possibility that you can achieve a more complete or even a full response over the next 8 weeks. And this is true even if your current dose remains the same and it's not increased any further. So now that you have an idea of how long it'll take for you to start feeling better, the 4th major question to take into consideration is, how long do I need to stay on my antidepressant? One of the biggest mistakes I see patients make is stopping their antidepressant medications too soon. So many people think that they should stop their medications the minute that they start feeling better, right? It did what it needed to do, now I don't need to be on it anymore. And this is wrong. What I tell my patients is that once your symptoms have returned to baseline and you're feeling back to your normal self again, this is when the stopwatch starts. From this point on, you want to stay on your current dose for at least another 6 to 9 months. And if you continue to remain symptom-free during this time, then we can talk about getting you off of your medication. The reason behind this is that if you pull that medication too soon and prior to the 6 to 9 month mark, you're at increased risk of your symptoms coming back again. And the evidence shows that continuous treatment with antidepressants decreases the odds of a depressive relapse by 2/3. And we know that the risk of relapse is the greatest in the first few months after stopping a medication. This is important when studies have shown that up to 40% of patients with major depressive disorder will have a recurrence within 2 years, and 85% will have a recurrence within 15 years. Now, does this time requirement change based on the number of depressive episodes you've experienced? Okay, so if you've had multiple depressive episodes, the answer is yes. This 6 to 9 month time requirement changes. There's evidence that you'd benefit from maintenance treatment for at least 2 years, if not longer. Now, you might be wondering, what's the big deal? Is there a long-term risk of me having multiple depressive episodes? Some studies are now suggesting that there's potential for depressive episodes to cause changes in your brain. And specifically, what we're seeing is a loss of volume in the hippocampus. And this is the structure that plays a role in your learning, emotional responses, and memory. And this reduction in volume has been shown to be directly related to the number and the duration of untreated depressive episodes that you've had. And not only are we seeing changes in its size, but we're also seeing changes in its functioning, meaning that people are having increased difficulty with cognition, particularly with memory loss. So we want to help you with both achieving symptom reduction and with preventing symptoms from popping back up again, because trying to reverse these changes in your brain's architecture and functioning could be difficult. Not only that, future depressive episodes could potentially last longer, be more intense in severity, and be more resistant to treatment. So please, do not go off of your medication without talking to your doctor first. Now, when you get to the point where you're ready to come off of your antidepressant, the fifth major question to take into consideration is, am I at high risk of having withdrawal symptoms when stopping treatment? It's been estimated that approximately half of patients will have withdrawal symptoms when stopping or lowering the dose of their medication. And the medical diagnosis we give to those who experience this is discontinuation syndrome. So what sort of symptoms are we talking about here? The way symptoms present can be quite variable from person to person, but what we commonly hear most about are flu-like symptoms, so things such as nausea, headaches, fatigue, and dizziness. But remember, everyone is different and people don't typically present like we read about in textbooks. And I've had patients even tell me about weird sensory experiences that they've had, such as brain zaps or electric shock-like sensations going through their skin. Now, who is most at risk of developing withdrawal symptoms? There are 4 major factors that I am constantly taking into consideration that I need you to know about. So the first factor that I take into consideration when determining if someone is at high risk of withdrawal symptoms is how long the patient has been on the medication for. Those who have been taking their medications for 8 weeks or longer are at higher risk. The next thing to consider is the dose of the medication. Higher doses generally equal higher risk. The third factor is the half-life of the medication. The half-life is the time it takes for the plasma concentration of a drug to reduce to half of its original value. And it's commonly used in medicine to estimate how long it takes for the drug to be removed from your body. So medications with shorter half-lives, such as Paxil or Effexor, often have more potential for causing withdrawal symptoms than those with longer half-lives, such as Prozac or Wellbutrin. And the fourth factor that I'm always considering is whether or not the patient has experienced withdrawal symptoms before. Because if they have, and this has happened with one medication, odds are it's going to happen again. Now, there are some other minor factors that have also been shown to put someone at higher risk, and these would include those who have developed worsening anxiety symptoms when initially starting antidepressant therapy, those who had difficulties increasing the dose of their medication because of side effects popping up, those who are receiving other centrally acting medications such as antihistamines or antihypertensives, those who are children or elderly, and those who are on antidepressants that have cholinergic or noradrenergic effects, with the most common ones being Effexor, Cymbalta, and Paxil. So now for the big question, number 6. How do I come off of my antidepressant? Well, there are 3 strategies that I commonly use to help patients avoid experiencing uncomfortable symptoms when stopping their medication. The first strategy I need you to know about when stopping your medication is that you're going to want to do this slowly and gradually. Studies have been conducted looking at the differences between discontinuing medications over time versus stopping them abruptly. And it was found that tapering medications for up to 14 days demonstrated no improvement or minimal improvement in withdrawal symptom severity when compared to abrupt discontinuation. What this means is basically that a 2-week taper is no better than a 3-day taper in preventing withdrawal symptoms. Neither approach is long enough. So when you come off of your medication, you're going to want to do this over the course of months to prevent withdrawal symptoms from popping up. And most patients take somewhere between 3 months to even a couple years to completely get off of their meds. And don't forget, the shorter the half-life of the medication, the more important it is that this rule is followed. So medications like Prozac, which has a long half-life, can generally be discontinued quicker than medications like Paxil or Effexor, which are notorious for having shorter half-lives. The second strategy that you need to know about has to do with how to reduce the dose of your medication. And there are two different approaches that doctors often take. The most common is a linear dose reduction. So an example of this would be when we're trying to get someone off of, let's say, 200 milligrams of Zoloft. We decrease the dose by the same milligram amount with each dose reduction. So if we're reducing Zoloft by 50 milligrams each time, we would go from 200 milligrams to 150 to 100 to 50 to nothing, right? Makes sense. The problem is that not all people tolerate this type of a medication taper. Instead, something to consider trying is a hyperbolic dose reduction. With this approach, the dose is decreased by the same percentage over time, right? This is different from the linear dose reduction where we decrease by the same fixed milligram amount over time. So for a medication, if the dose is reduced by 20% the first time, you then reduce it further by another 20% the following time, and then so on and so on. So what you see is that the total overall dose from a milligram perspective gets smaller and smaller with each dose reduction. So what percentage dose reduction wise should we be aiming for? If you're someone who is at lower risk for withdrawal, we can start by decreasing the dose by around 20 to 25% with each medication change until we get to zero. However, if you're someone who is at higher risk for withdrawal symptoms, or someone who doesn't tolerate reducing the dose by 20 to 25%, you're going to want to decrease the dose more gradually and slowly. And it's been suggested instead that the dose be decreased by around 5 to 10% with each reduction. Now, an issue that you're going to run into with this approach is that these medications don't come in tablet or capsule formulations that support these unconventional doses. So what we'll do instead is prescribe the liquid formulation of your antidepressant. And if your antidepressant isn't one that comes in a liquid formulation, liquids will have to be compounded by a compounding pharmacy. The third strategy to help prevent withdrawal symptoms is to switch your current antidepressant to a different one that has a longer half-life. It's not uncommon for some people to really struggle with even the smallest dose changes of their antidepressants, and this is typically seen with medications that have a shorter half-life. What we'll do is switch you over to an equivalent dose of something like Prozac, right, which is notorious for having a longer half-life and with being associated with lower incidences of discontinuation symptoms. And this switch can be done relatively quickly and without much of a delay. Then what we'll do is we'll work to gradually reduce the dose of Prozac until it's completely out of your system. If you're still thinking about trying to get off of your antidepressant, make sure to talk to your doctor about which of these strategies would work best for you. My friends, don't forget to check out the link below so that you can download my Antidepressant Beginner's Guide if you want to learn more about the top 10 commonly prescribed antidepressants. This booklet is your path to feeling better faster.